wouldn't want to let go doing cancer care reviews to care coordinators or to non-clinicals because they are thinking the risk that something might be missed. But I think now it's becoming more GP trusting care coordinators to do it because they're seeing the benefit of it, and care coordinators have more time to do it, and they can offer face-to-face. Some of you will do home visits as well. Yeah, these are just additional platforms that you can visit as well. This is the thing that I wanted to share with you. This is in your booklet as well, and there is a QR code for that, so you can scan that. So this is specifically for cancer patients about their pain, their fatigue, fear, anxiety, and so on and so forth. So these are the things that you can look at. There's so many online e-learning things that you can use also, and you can match your skills and knowledge on this one. And most importantly is the ASCEND program. It's Aspirant Cancer Career and Education Development Program. So it is a guidance on knowledge and skills. So you can also enroll this one, and the link is there that you can. It's a very new site that just been developed to support your knowledge in cancer. And this is for everybody, nurse specialists, general practitioners as well, primary care is also. You can access this, and you don't need to have the NHS account to access this one. Am I right, Mark? With the ASCEND, you don't need an NHS account, isn't it, to register with them to access
you
it?
currently do.
Oh, is it?
Yes, but there's going to be a move in the next 6 months to make it more widely available outside the NHS.
Yeah.
If you log in from a NHS computer, you can access everything pretty much. And there's a couple of really good courses for like foundations of cancer care courses, great for people who don't work with cancer patients every day but want to top their knowledge. It's really good stuff.
Yeah, and also cancer framework as well. They do have. So I think that's all. This information is in your booklet, so I don't need to expand it, and you can access them and find out for yourself for your information and learning. And I think that's it from building knowledge. Sorry, I need to cut it very short, but if there's anything, you can email me, and I can support you, and I can give you links as well. So every month I was doing the sharing best practice for care coordinators, which is very successful. And yeah, we had our last session last May, and I don't think we will have next, and I don't know who would continue, but I think my colleague from Buckingham and Oxford might be able to continue it, but we'll let you know. Okay, I think our next speaker would be Catherine Bailey, nurse consultant from Berkshire, and she's my line manager.
She's very scary.
The reason that I wanted to present this is because I just wanted to explain what we did in breast for a stratified pathway, because it's kind of, we developed it. So I inherited the database in COVID, and then everybody was put on it, and since then we've kind of tried to develop it and enhance it so that it helps both the patient and people in primary care kind of like manage the people that have had finished their breast cancer treatment in the hospital. So these are only primary breast cancer patients. This is not secondary. Happy to talk about secondary or breast cancer patients at the end, or questions, but this is the biggest cohort of breast cancer patients that we have going through the Royal ARRS. Personalised care pathways, so it was in the NHS long-term plan for cancer. and it should include signs and symptoms so that they know what to look for when they've finished their care. It should offer rapid re-access to their cancer team. It should give them regular surveillance while they're on this pathway, and personalised care and support planning. And everybody always talks about discharge. This is not a discharge at this point. It is a transfer onto a different pathway of care. And I think we need to stop saying to our patients, you are now discharged. If I could get the doctors to do that, that would be absolutely fantastic. Because I think people feel they've come and we've been looking after them and then they're dropped off a cliff edge. And that's not just in breast cancer. So all these principles can be applied to any of the cancers that we have. It's just, this is a big cohort, and I know that Nikki's team in colorectal are doing that. That's another big cohort. So they're doing something similar. And we will be bringing the other bigger sites on with this kind of thing. So basically, came along and they were basically just sending them off with a letter and saying, go and look after yourself. That was a very difficult time for all of us. We didn't know what we were doing. But it gave me time to think about how we should support people and how we need to bring everybody together, including primary care, to kind of like support this patient through their pathway of care. So, a referral to open access is the start of a pathway of care. It's a pathway of self-supportive care. They've kind of finished their hospital treatment, and what in the Royal Arts, the clinician, whoever that is, it can be the surgeon, it can be the clinical oncologist who's given radiotherapy, it can be the medical oncologist that's finished their systemic anti-cancer treatment. I do quite a lot of them as well. We have a consultant radiographer, they also transfer people on. And so basically, they're put on this, they do this data entry summary, and they press a button and they fill in the thing and it says add to the open access database. And as of the 30th of the 5th, we had 1,584. This morning we had 1,601. It goes up and down all the time, but the trend is upwards. We've had 55% increase in referrals in the first 3 months of the year than we did last year. So the referrals are coming in. We're transferring people much more slickly to this pathway of care. The majority of people stay on the pathway of care 5 years after diagnosis. If there's BRCA, if they've got family history, if they've been diagnosed under 50, they will stay on till 50 or 59 or 60 dependent, and that is all put in this database treatment summary. And so from that, what we do is I have a whole-time equivalent cancer support worker. There are two within the breast team, and they kind of part-time share this, so they cover people when on annual leave, and they are an absolute godsend. And they summarise our treatment summary, and they put it in a letter, and they send it to the patient. So it says, dear Mrs. Ross, this is a summary of your treatment, and I'll show you an actual patient summary in a minute, and it's copied to the GP. Within that, embedded within that, is a signs and symptoms leaflet of secondary and recurrence. It's produced by Breast Cancer Now. I helped design it because they had one for recurrence, but they didn't have the secondary symptoms on it. So we've combined it to an A4, and that goes out. It's an as attachment though, and of course everything now goes out as a link. So we have to, we have to make sure people are aware to press on the link to bring these things up. So this is it. This is it. They would get all these pages. So 2 pages. I've got it a bit bigger in a minute to show you. But this is the letter that goes out to the patient. Okay. Right. Is that a bit bigger? So, and it explains that open access follow-up. We call it OFU, and we should, and it's a copy to the patient. It goes through, and then I've put the codes here. Not really for you to do anything. I know it says GP action, but I know that things are highlighted to GP's practices. So it's more about its information that you can code it as these things if you've done it, and also to prompt if you haven't had the 12-month cancer care review to do it. I have a bit of a thing about the timing of cancer care reviews. Some of our patients don't finish till 2 years or 18 months, and actually they're seen in the hospital very frequently, and is it actually that should be extended out a bit? whether it should be an end of treatment cancer care review in the community. So these are things we need to develop. And then it will say the duration and type of endocrine therapy. You know, so the whole thing, so that the GP would know. We've started prescribing it from January 2023, and they're on it for 10 years, so I'll finish prescribing it in January 2030, basically. There is information, so as it's a self-supported pathway, and we were getting lots of telephone calls from the breast care team about endocrine side effects and menopause, I now have developed an online workshop that everybody who is having endocrine treatment is invited to. And I'll explain that a bit more in a minute. Then it's about the mammographic follow-up, and it will say you're due the next one, and then you have more, and it says we get a letter out, so the cancer support worker on a Tuesday reviews every mammogram that has been done the week before. M1s and M2s, automatic, they send out a letter saying it's a normal result. M3 is brought back in very quickly through the radiology department, and I monitor them through NDT to make sure that they're either back in a pathway if they're recurrence, or back to OFU if they have it's a fibroadenoma, scarring on the surgery line, a bit of lymphedema, and if any of those kind of things come up, we would then refer on to the different people that are needed. And then, because if there are aromatase inhibitors, they would need DEXA scan with a bone density. So we put in that you will have a bone density scan. They have a baseline one if they're not on adjuvant zoledronic acid, and zoledronic acid or a bisphosphonate is given as part of their cancer treatment in a certain population of patients. So that's explained in there. So if you have bisphosphonates, you have it at year 5, and we would do it just before we discharge someone. And then they may need more in the future, but the metabolic bone service takes kind of ownership of the results and would send it out to the GP and the patient. And then we have a self-management section to it. It says the signs and symptoms, and then it talks about holistic needs assessment. And that all hinges on, if you see in this line here, on Thursday, the cancer support worker says, I will phone you on that day. And what they do is they go through all of this to make sure the patient thinks their treatment summary is correct and they understand it, or they don't understand it. You'd be surprised. I was told it was 14 millimetres a week, but 15. You know, there are typos that happen. So actually, it's very good, and they really like the cancer support worker just spending 20 minutes with them, going through, yes, that looks all right. They will say, have you got your attachments? Have you looked at the signs and symptoms infographics? Have you opened it up? You know, do you know how to contact us? And then there is it says that all general inquiries, the Macmillan support worker, and that's our telephone number. They also, at that point, at the telephone call, will invite them to the endocrine workshop and ask them if they want a holistic needs assessment. Now, this is the thing about holistic needs assessments, they are offered, and lots of people, one, don't understand what they are, and two, will just decline them. I don't want to bother your time. So we feel that by asking them a bit more proactively, we kind of get a better uptake of those. This is the signs and symptoms leaflet that would have gone, and if they're on endocrine treatment, we add this is an internal, I think it's 4 pages, just a very basic endocrine leaflet, just in case. They should have got a Macmillan leaflet when they were put on it and that, but that's just what happens with this. Oh, I've kind of gone over on what I just said really. So then it continues, they have the telephone call, then they come to the endocrine workshop, and we run that, so that's an online workshop with myself and a psychologist, and it's about every 6 to 8 weeks, because some people say yes or no. It's a 2-hour slot, and we talk through, so I do, this is why you're having endocrine treatment, why you're having the type of endocrine treatment you're having, and for how long, why, and I have a little algorithm that I show them, very basic, so they understand why they're on 5 and not 10, and why the lady next door's got a different one for them. And I go through menopausal symptoms, because that's what it is. It isn't anything different than having menopause. And we talk about self-supported care, how to deal with hot flushes, the bone density stuff, and then we talk about perhaps you should go and get your cholesterol and BP checked, because the AIs can raise that. So allowing them to take charge of some of their health, because that's the thing about self-supported care pathway. It's all right as long as you've given them the information and the kind of support to allow them to care for themselves. And then in the second half, one of our cancer psychology team talks about how to kind of think about the menopause in a slightly different way, because lots of research that says if you go think you're going to have a bad menopause, you're going to have a bad menopause. So it's about reframing. She does a bit of CBT. She's got really minor stuff kind of thing, but actually we've linked in. I know that talking therapies are looking into doing more of this kind of thing for the general, for 50% of the population in Berkshire West. So it would link into those kind of things. This is very kind of early on kind of stuff, but she does that, and it's really well received. And they get a resource pack that we send out about things, and then they are offered their final, so their end of treatment kind of holistic needs assessment. The telephone call happens about 6 weeks after they've been transferred, and then the endocrine workshop would probably be a couple of months after that, and then the holistic needs assessment should be a couple of months after that. So it's a bit of a transfer of care rather than you have just been dumped in the world. And this is a care plan. This is what would end up on our EPR database, our electronic patient record kind of thing. It turns up like this. It says it's my care plan. It doesn't have a holistic needs assessment in it. It doesn't come to you with holistic needs assessment. It's a care plan. You have to look for my care plan. And this is someone's, and you can see that the patient had pain and discomfort, other medical conditions, difficulty passing urine, sadness and depression. And they rated their kind of concerns at that time. And then there was just notes about her shingles vaccination, and we do put, please arrange a cancer care review. It's just a prompt, it's not an instruction, it's just to kind of encourage. So please don't think I'm telling you. It's not my place at all. And then they have their surveillance. So we like I say, the cancer, we have about 35 to 45 mammograms a week to review. The results letters sent out. I order all the next year's ones. Or the patient is discharged with their final mammogram. And within that results letter of the discharged patient, it will say, you started on endocrine treatment at blah blah, you were recommended 10 years, this should finish. Just as a kind of prompt that they've got a time scale. And that we also check if the abnormal results are being followed up. DEXAs. So we, whilst they're doing the mammograms are kind of fairly easily, they're easy because they're reported and ordered on our EPR. DEXAs aren't, they're still done on a piece of paper. So we can't proactively do anything with it. We basically, the cancer support worker, when she looks at the mammogram, she checks if they need a DEXA or not. And we fill in a form if they're having it within the next year kind of thing. We've got a folder of it. I'd like them to be, they keep saying they're going to go electronic, but we haven't done that yet. They also, what they do is review anybody that hasn't had a mammogram. Our database allows us to look back and says these people haven't had a mammogram, and we cut it off at 14 months. So in the last 14 months, in case someone's had a delay or they've been away, so it wasn't the 12 months. And so there are reasons why people don't have mammograms. They've had bilateral mastectomies. Some people that have chosen not to, and we write to them and the GP. But anybody that should have had one, that hasn't had one, is wrong by the cancer support worker. Why haven't you had it? Moved out of area, haven't told anybody, this kind of thing. Oh, I didn't think it was important. We kind of encourage them to come back into the mammogram list. And then they can, and what's important, that initial telephone call, is that they can re-access or speak to the breast care nurse or the open access follow-up team, all on the same number, or referrals back into the service. If someone says they've got a lump on their scar line, they go in as a kind of 2-week wait. So the pathway is like a 2-week wait because we need to make sure it's not a recurrence. So they would come in and see one of the breast practitioners, they may do a biopsy. Lots of the time it's lymphedema of the breast, post-radiotherapy changes, that kind of thing. If they had pain that didn't go away, nausea, weight loss, then we might move it back to the oncology team. I might order a couple of tests before we do that, blood tests. I've got a lady at the moment who's got pain in her hip that hasn't gone away. We were discharged her 4 weeks ago, but we're going to do a hip x-ray, we're going to do an ALP, that kind of thing. And then if she needs to, she'll come back into our oncology clinic. I run an endocrine clinic, so as well as the workshop, if someone is having trouble with their endocrine and it's not working for them, then we will talk about endocrine swapping to different ones. I will also just talk about the risk and benefit of actually stopping their endocrine treatment, because some people just don't want to take it, but we'll try and encourage them to take it. This is about encouraging adherence as well as, managing their symptoms. I do a lot of work around vaginal dryness, lots of questions about can I take HRT and can't I take HRT, vaginal estrogen. So that's all dealt with in that clinic, and I get letters from GPs saying, I'm not sure what to do with this lady, can they have that? And usually I would speak to the patient and then reply to the GP. We can refer to psychological services, cancer rehabilitation team, they're speaking to you later. We have lymphedema services, we have a breast physiotherapy services, or it might just be for reassurance and support. And this is for the time they're on the duration of OFU. And after that time, it's a referral back in through 2-week wait. And so part of the reason that I set up the pathway in this way was a long time ago, was a community palliative care nurse, and the amount of information you got in primary care about anybody was it was difficult. It was very sketchy and that kind of thing. And I think when people are going out, they're not sure themselves, and then the people that they go and see in primary care don't understand it. So I just felt this was a helpful summary of what, but I don't know if I'm doing it right. So I'm always happy to have comments or queries, or actually the snowman code's on right, we would rather have them, can you put this on there? More than happy to do that. And Cargill,
Probably gone back to work.
okay, the Berkshire, we have a Bob ICB West Berkshire Cancer Group that meets monthly on a Tuesday. So via Cargill, any suggestions for these kind of things can be brought back into there. And the thing that we're not doing very well at the moment is long-term effects. And that's across the board. So I'm happy to take queries into the breast team, or there's an oncology general email address. I think it's oncology@RBPH Trust. A letter into that. If it's about a breast patient and signs and symptoms, then we would look at it. But it needs to be a two-way thing. I've set this up. I hope it's helpful. I don't know if you see the letters. I see breast patients all the time. You probably see one a month, maybe. So where they're there, I don't know if they're there. But it would be nice to get some feedback. And I think that's. Oh yeah, that's someone else. It's not me. Yes.
Hi, I'm talking about the medication and the prom. I actually had someone call me yesterday that has finished their treatment and is on that.
Yeah.
She's been on it a couple of months, she's 70.
Yeah.
She wants to stop taking it.
But she can't stop taking it.
So I said to her, she said, what should I do? I said, well, you need
Yes,
to speak
yeah.
to the breast nurse. I don't think she knows anything about this workshop or.
Well, she won't do yet because do you know if she's had the treatment summary?
I don't.
No. So it's a bit of a pathway of care. So if she hasn't been put on OFU yet, this is the thing. It's not an immediate thing. And actually it is. And so what you need to do is make sure that that's the bit that's happened next. But she should have the breast care nurse's number and she should speak to her. Yes.
Because she said that she's not sleeping because her pains in her joints,
Yeah.
hips,
Yeah.
and everything else.
Well, we can swap, you see, and that's why I run the clinic
And I said to her,
beforehand.
they may
swap it. Yeah. No, and so in the back of the booklet is the email addresses and the contact numbers for the breast care nurses, as well as some of the other CNS teams. Yeah. And our cancer support worker, and make sure she's got that number and give her a ring. Yeah. Sorry, yes.
Thank you. Actually, a question for my colleagues here as well. Well, that sounds like a very good attachment to your transformation letter rather than discharge letter. I've never seen it. Very, very occasionally, we receive the care plan. Maybe 1 or 2 a year. I don't know why it's so scanty. But I've never seen the attachment, whether it's been sent to the patient but doesn't reach the GP surgery.
So the attachments on the care plans and the attachment on the treatment summary.
Never received it.
Well, which one are you talking about?
The attachment to the well, not discharge letter, but the transformation letter.
The
transformation letter arrives.
Yeah, but that's not attached to the care plan.
It's separate,
That's
so that's
separate.
It's a separate letter.
Absolutely, yes. That's what I'm saying. The occasional care plan, very, very scanty. But discharge letter or transformation letter we receive. I've never seen the attachment without using.
You won't see the attachment. There should be a link to it.
In the letter.
Yeah.
Okay.
Well, if you're not getting it, if you can send me the NHS number of anybody that hasn't got that attachment, then I will speak to our electronic record. You know, the people that do our letters, because if the attachments aren't going out, then I need to know. And that's partly why we did the telephone call, because we had some people saying that they hadn't had the attachment. So when we speak to them, lots of people say, oh, I haven't opened my attachment, so they haven't seen it. But I am more than happy if you get that kind of thing, if you email the breast care nurses and say, we're not getting the attachments, then I need to speak to the people that put the attachments on. Thank you.
Okay. Thank you.
Anything else? And I'm happy to field questions. Yes.
Dr. Tucker is right. I work with her as a care coordinator and another surgery. It's not just the, we receive the summary,
Right.
we don't receive the HNAs, and we do not receive many times, and it's random. Some patients, I've had interaction with Joyce, we were making sure that there was a patient, we were taking it as an example, to see if we received it and has been coded. Yes, we received that one, but not the others. So it's really random.
The thing about that is then I need kind of
examples.
So, you know, absolutely, and actually, I'm more than happy to give the open access follow-up email, because then we can link. That would be really good to get some names and numbers, so that we can then go, because if it's going to the patient, I'm not sure why it's not electronically through EPR coming to you, and that might be that. I mean, EPR is a law. I can't.
I think another question very quickly, I'm terribly sorry.
No.
The patients on ARRS inhibitors,
Yes.
supposed to have DEXA scan every 2 years. On the summary, it says, well, they'll be discharged back to GP after 5 years, but they're supposed to be.
They are, and our metabolic bone service said that after 5 years of our discharge, it was in their letters that they send, rheumatology letters they send you, this should be, if it's been after the 5 years, it should be arranged by the GP. It says that in the
That's
letter.
after 5 years,
Yes.
if they didn't have it, or
No.
if they're supposed to carry on every 2 years whilst they're on treatment.
Yeah.
Who is arranging that?
So at year 5, when we discharge them, it will say,
I'd say it's us, since then it's
GP.
GP's deleted, it will come to be a GP,
Yes.
it will come to be,
yes.
alright, not very cool.
And I inherited that pathway when I came here from rheumatology. I didn't make that up, if you see what I mean. Yeah.
Yeah, that's fine, thank you.
Yes.
I was just going to ask,
Yeah.
is there a general information piece that we can then give people about this process?
There's an open access follow-up leaflet that they should have got before they put on it. So we should have. So that if you go to the patient information leaflets on the trust website, it's on there. Open and if you put in open access, it should come up. But they should have it. If they don't, then yeah, they should have it given to them as they go onto the open access by the clinicians. Yes, hi.
Thank you.
Sorry.
literacy in our area is over 70.
Yes.
So what I'd ask as the primary care lead is if you've got that sixth sense of this is not going to go well, send an email to the, just we need something.
What I should have said as well is if I don't think someone can self-manage, they don't go on this. Okay, so anybody with dementia not going on this, they can't look after themselves, they can't tell me we've got a lump, not happening. We've had a couple of people with severe mental health issues. I've said to the doctors can't go it. So we do have a routine, you know,
that would be a really good
thing.
combination.
Yes.
We can then work with
Yes.
you
Yeah.
and support.
Yes.
Because quite often we know
Yes.
why, we know the.
Okay, so I need to think about how, for those people, we still do a treatment summary, but we actually say we're still looking after them in primary care.
Yeah.
Do
Or
you
we
see what I
just,
mean?
we red flag them and
Yes.
then we can put them
Yes.
as high risk.
Yes.
Not because of their cancer,
Yes,
but
because they're.
whatever.
Yes. Yeah. Okay. No, I'm happy to
There
take
might
that
be that
away.
many, but it would be really helpful.
And the other thing we're trying to look at is, as a wider project, is signs and symptoms of late effects. But that's a Bob thing.
Especially biologics.
Oh yes. Yeah. So and that's, like I say, happy to have any suggestions, and that's me and the CNS team leader Nikki at the back. Okay. I'm gonna shush. Thanks.